Just to start with, can you tell us where and when you went to medical school?
I went to medical school at the University of Pennsylvania and I graduated in 1955.
Okay. And where did you go from there?
And then I interned, I took a rotating internship at the Pennsylvania Hospital in Philadelphia for 1 year. That's the oldest hospital in the country, founded by Benjamin Franklin. And then from 56 to 60, I was a resident in pathology at Mass General in Boston.
Okay. What brought you up to Boston?
Well, a good residency program.
Okay, great. When did you come to Worcester?
Well, actually, I was born here, so
Okay.
I came in 1929 originally, but I came back to Worcester to practice in 1962. I had been out here in 1957 as a resident. The Mass General used to rotate out to Memorial Hospital, and so I'd had some familiarity with the people who were out here.
What made you choose pathology?
Well, you know, in the 50s, many people used to take a year of pathology trying to make a decision as to what they wanted to do, and it was always considered a good thing to do. You solidified all your basic sciences, and when I got into it, I said, gee, I mean, people actually pay you to do this? And so I said, I think I'll just stay in it. So it was sort of a side door approach to it. I thought I might want to go into internal medicine at one point.
Has pathology as a specialty changed over the years?
Oh yes, I think it's changed a great deal. Certainly when I started out, pathologists were more generalist. We were in the 50s, we were more like general practitioners of pathology, and we ran all the laboratories, not just the anatomic pathology laboratory, but we ran the chemistry laboratory and the bacteriology laboratory and the blood bank, etc. And through the years, of course, there's been this centralization of all kinds of facilities, so that the hospitals have consolidated, and as this has taken place, a lot of the individual laboratories have been directed by specialists in these areas, so that particularly now in our organization here at UMass Memorial, we have people who specialize just in blood banking and others in microbiology and etc. So there's, and as a matter of fact, even in anatomic pathology, we used to all be generalists, and now we're becoming increasingly specialized, so that people do limit themselves to organs.
Do you think that's a positive change?
Well, there are pluses and there are minuses. I think certainly being able to do general pathology, general anatomic surgical pathology is a plus, because it gives you a different perspective than if you become too narrow, and because a lot of these diseases manifest in different organs, and I think it's very helpful to have a good background in anatomic changes that take place in all organs.
When you were in your residency, what was a typical day like for you?
Well, in our residency, we used to start at around 7:30 in the morning, and we would have an autopsy review conference. And at that time, autopsies were very popular, and we at the Mass General we were doing 1,200 autopsies a year, whereas now we might do 12 a year at the Memorial Hospital. And as a consequence, we had lots of cases that had to be reviewed, and we used to all sit around a table with the chief of pathology and review all the organs from the autopsies of the day before and discuss the cases, and this would take an hour and a half or so. And then we would go to our various rotations and either start doing surgical pathology, processing specimens, do frozen sections, or we would, if we were on the autopsy service, we'd go do autopsies, or if we were assigned to clinical pathology, we'd then go off to one of the laboratories and do chemistry or blood banking or whatever. And then at noon, 1 o'clock, we used to reassemble, and we'd have a slide conference, and all the interesting material of the day would be out for us to review, and then we would have it projected on the wall by the chief of pathology and discuss each of the cases. And then we would, that afternoon, or late afternoon, we'd get the slides from the surgical cases that we had put up, and we would start reviewing them. Then we'd go home, and we'd end around 11 o'clock at night. So that was a standard day in pathology in that era.
How has that changed now for residents nowadays?
Well, I don't, well, they work very hard now too. I think that the scope of material has changed a great deal, of course, because of autopsies have become much less frequent, and if anything, it's a big problem now to find enough cases to train people, and surgical material, of course, has perhaps become more extensive. We do bigger cases now than we did then. We now have transplants and major liver resections and things of this sort, so that they're more complex cases perhaps in surgical pathology now. They work hard now too.
When you came to Worcester, what was practicing like for you?
Well, in 1962, Worcester was a bastion of private practice. Everybody in Worcester was, with a very few exceptions, was in private practice, and but each of the hospitals had its own teaching program. As the system evolved, we started by hiring a full-time person who would be the director of medical education. And then through the years, of course, the situation has changed where more and more people have come to work for the institutions, and less people seem to be in private practice.
What sort of cases did you see when you first started?
Well, we had at Memorial Hospital, we had a very good mix of cases because most of the specialties of that era were represented. We had neurosurgeons, and we had urologists and thoracic surgeons and abdominal surgeons, etc. So that we saw a very good mix of cases in that era, and I think actually some things that now get referred out did not get referred out in that era because there weren't the subspecialists in other major centers. I'm thinking, for instance, of bone tumors. They used to be treated locally, and now it would be quite unusual to have a major malignant bone tumor of an extremity treated locally, at least at Memorial Hospital.
What are some changes that you've seen in technology?
In what?
In technology, the technology that you
Oh,
use.
in technology. Oh, well, we've gone through a tremendous revolution since I've been here. And I think back to the clinical laboratories. When I got here, we were just beginning to have automated chemistries. And we had an instrument called the Autotechnicon, through which we could do just glucoses. And then they evolved the system so that we could do glucoses and BUNs. And then eventually it became a 12-channel instrument. And then, of course, a whole variety of automated chemistry instruments came out as time went by. This technology has, of course, been across the board in everything we do in microbiology. We used to simply look at the Petri dishes, try and identify the organisms. We made our own substrates of various chemicals to try and biochemically characterize the organisms. Now they come pre-made and tied into computers, et cetera. We used to have to look at the blood culture bottles, and now, of course, there are instruments to identify growth inside these in an automated way. Surgical pathology has changed tremendously. We've had automation of our staining procedures, of our cover slipping procedures, of our labeling procedures. And of course, the big change has been the computer, because now everything has become computerized.
Is there anything that stands out in your mind as being the most challenging aspect of pathology that you've experienced over the years? What have you found most challenging about your field?
Well, the most challenging, I think, has been to try and maintain one's skill with surgical pathology, because in the last 40 years, many new variations on the theme have been described and developed and subclassified, et cetera. And a lot of these new entities that are described that used to be lumped under a large entity now have therapeutic significance, so it's important that you try and stay familiar with all these. Thinking, for instance, of the lymphoma group, which has undergone tremendous changes in nomenclature and characterization, et cetera, all through the development of monoclonal antibodies and allowing us to characterize things differently. And in the old days, there used to be reticulum cell sarcomas and lymphocytic lymphomas, and that was about it, and it really didn't matter whether you got them right or wrong, because there wasn't much to do for them.
Wow. So now that there is the availability of therapeutic medications, what does that imply for the pathologist?
What does that imply for the pathologist?
Like, what do pathologists now have to do?
Well, it's more important than ever that we get it right, and that we get it subclassified correctly, so that the correct approach is done. And for instance, in the old days, when we were dealing with breast tumors, usually they presented as they were discovered most often by the patient as a lump, and usually the lump was about the size of a walnut, and the only question was, is it cancer or isn't it cancer? Because if it was cancer, then they would do a radical mastectomy and take out the breast and the axillary lymph nodes. And of course now, in breast pathology, there's a whole spectrum of proliferative changes that take place in the breast, and some are in the so-called gray zone. They're not easy to interpret, and it's important that as an example, that we characterize these women correctly, so that they end up with if they need a wide excision, they get it. If it's a border benign lesion, that they're not mutilated, and some of these anatomic changes are quite subtle and difficult and have some personal judgment involved in them. And this applies to every organ we deal with nowadays, because the therapies are much different depending on what the diagnosis is.
Have the diseases changed much since you started?
Have diseases changed?
Yeah.
Or some diseases have gone away, have disappeared, and then we're dealing with some new ones now.
Yeah, can you talk a little bit about
Sure. And, I remember in 1955 we had the last great polio epidemic, and it was really devastating. It was a very virulent form with a lot of bulbar polio, which involved the destruction of the nerve cells in the brainstem. So a lot of these people were put on the equivalent of respirators. They had iron lungs and things of that sort in those days. And they had this very severe paralyses. And then the following year, the vaccine became available. At first, it was the Salk vaccine, and then we went the Sabin vaccine, the live vaccine, came out, and the disease just disappeared pretty much. I mean, occasional sporadic case, but for all intents and purposes, this is a devastating disease that up until 1955 everybody worried about. And in fact, in 1955 everybody worried about it. I remember when I came up to have my interview for a pathology residency at the Mass General, all the residents were shaking in their boots because they were doing autopsies day after day on patients who were dying of polio. And they said, "Are you sure you want to get into pathology? This is a pretty risky business." And the next year, of course, there was a way to protect yourself, and so that was a disease. That is an example of a disease that has disappeared completely. And then, of course, we didn't have AIDS or HIV. That was described, I think, in the early 80s, the first few cases, and so that was something we did not have to contend with.
Were you seeing patients who you believe were dying of HIV before it was even known that HIV existed?
That would have had
I've talked to some doctors who believe they were treating people who were infected with HIV and believed that there were patients who were dying of HIV, but that was before they even knew what the virus was or that there was a virus. Do you remember anything about that?
Well, I don't. You know, the original cases there were certain criteria, as I remember, way back about 18 years ago or so. It had to be met to make the diagnosis of AIDS, and usually it was somebody who was either had to be gay or you had to be a Haitian. There was a focus that was coming out of Haiti at that time, and there were some other criteria, and other than that. You didn't meet. If you didn't meet one of these criteria, you weren't considered to have had the AIDS because there wasn't a serologic test at that time. I guess you're asking me, were there cases of HIV around prior to the description? I suppose there may have been some cases. Not the first case described, I suppose, doesn't have to have been the very first case that occurred, but I don't think it was very prevalent, or we probably would have known of it.
So HIV really came to Worcester later.
Yeah, I think it, and Worcester, I don't think had the influx early on that some of the big metropolitan areas had. We didn't have the drug problems that in Worcester that existed in some of the major cities. I remember when I came in 1964 or 5. I remember a police lieutenant came to Memorial Hospital to describe to an incredulous staff that there were some drugs now in Worcester, but it was so uncommon at that time that people did. There certainly wasn't the first thing you'd think of, and of course the drug problem has increased all over, including in Worcester now. But so I don't think we had the first cases in Worcester of HIV.
How do you think the emphasis on disease prevention has affected medicine? Oh,
I think it's had a tremendous impact on disease prevention, on what we see. And I suppose the biggest area is in cardiovascular disease, where the risk factors have been identified pretty well. I mean, obviously there are some more yet, I suppose, to be discovered that as time goes on, but I think that there's been a tremendous reduction in cardiovascular disease. When I started out in pathology, it was not at all uncommon to see people dying of massive intracerebral hemorrhages, strokes, and they were doing this because they had severe hypertension, because it wasn't a good way to control hypertension, and it's certainly within my lifetime, medical lifetime, where good control of hypertension has occurred. In the early 50s, we used to use phenobarbital as a way to control hypertension, and all it did is make the patient sleepy. It really didn't lower their blood pressure. And then, of course, the diuretics came, and then the very beta blockers, et cetera, have appeared on the scene, and much more specifically. But the changes in the cardiovascular disease have been tremendous. And likewise in cancer, of course, we've seen big reductions. When I started out in pathology, we used to see a lot of women dying of carcinoma, invasive carcinoma of the cervix, and now this is very, very infrequent. It's as a consequence of pap smears.
Interesting. Were there epidemics in Worcester, and what was the worst epidemic you recall?
Do I recall? Well, the last epidemic in Worcester, I wasn't around. It was in 1918, and it was the influenza epidemic, and that was in Worcester. And the reason my grandmother died in 1918 of the influenza epidemic, and I went to look up her obituary, thinking I might learn a little bit something about her, and I went to the Telegram and Gazette. She died 11 years before I was born, so I never knew her. And when I found the day that she had died, and there were so many people who had died that day that all I did was list the names on the front page, like we would in a disaster. There was a whole list of names, but it gave no other information. It didn't have enough room on the obituary page to tell you when they were born or where they had come from, et cetera. But that was a big epidemic. And then we had the little polio epidemics every summer, and every parent used to be terrified that their child would contract polio. A lot of us weren't allowed to go in swimming pools in the summer because there was some people did make a connection that maybe the polio virus was transmitted through the water. And I think they probably were not too far off that this was a oral fecal route.
When the polio vaccine made such an enormous difference, what was the general mood in medicine?
Oh, I think we're all elated at that point that this disease had been conquered.
Did it raise hopes that the same thing would happen for other diseases?
Well, I think the expectation was that we'd be able to vaccinate against all kinds of viral diseases, and of course that's what's happened. When I was in medical school, I had the mumps. Well, that was my reward for my rotation on pediatrics. There was no mumps vaccine at that time. And when I was in the infirmary, there were three men in the infirmary on the top floor at the University of Pennsylvania, and one had the measles, one had the mumps, and one had chickenpox. And of course now, nobody should be getting any of these diseases.
You mentioned when you first came to Worcester that there was very much private practice oriented. How has government intervention changed, in your opinion, the way medicine is practiced?
Well, I think that many more physicians have become employees in one form or another of large organizations, and so they probably have less autonomy and less able to dictate exactly what they do. They no longer work entirely for themselves. They've rid themselves of all the concerns of operating a business, because each private practitioner had to worry about staff to pay and buildings to maintain, et cetera. But they did have a lot more freedom, and they worked hard. They may have had freedom, but they of course, didn't have, if they took a vacation, they didn't get paid, and they had to maintain their office staff, et cetera. So I think they did work very hard in those days.
How did physicians in those days learn how to run a business, how to run their practice?
Well, nobody they all learned by themselves, I think, because there was certainly nobody talked about it in medical school or residency. I think the physician's first exposure to running an office in small business was when he came out and went and practiced. Not infrequently, a younger man would go and practice with an older person, and I suppose he learned some things from his predecessor, depending upon how good a manager his predecessor was.
Could you speak a little bit about how you feel managed care has affected medicine?
Well, yeah, it's. I think that the business aspects of medicine have really started to dictate to some extent what happens to patients, and I think that people who are making decisions that should be made, non-physicians are making decisions that probably are in the province of physicians, and I don't think it's a good thing in general. I mean, when people dictate the length of stay for patients, and when they have to go for prior approval by lay people as to whether a procedure can be undertaken or not, I don't think that's in the best interest of the patient. We used to, prior to the advent of managed care, I think medical staffs did a very good job of policing their own medical staff, and we had different kinds of committees to address situations like this, tissue committees where we would review the necessity of surgery, and we'd had mortality rounds and morbidity rounds, etc. They used to be very critical of, there used to be a lot of self-criticism taking place.
Have you found that this has changed the way physicians view medicine, their personal opinion, like how happy they are practicing medicine, with their autonomy being taken away in some instances, or?
Well, I think there's some element of disgruntlement by the physicians who certainly, I know there is where they have to go through layers of bureaucracy in order to have something carried out that they know should be done immediately, and they have to run it by many people before they can actually advise the patient to undergo a procedure.
Do you have any ideas on how you would like that to change?
How you
would like the current managed care system to change?
Well, I'd like to see more autonomy returned to the physicians, more of the decision-making process put back in the physician's court, and with less outside interference. I don't know whether you can do this with a bank, if you will, of give a physician a certain degree of latitude, and there are some patients that, for instance, should exceed the length of stays that are now given, and rather than question the physician on each individual case, maybe you should look at the end of the year and see whether a physician exceeds his parameters, but stay out of each individual case. Let the physician make his own decisions.
Do you think physicians could have been more involved with the advent of managed care, with making policy decisions? Has it been left too much in the hands of non-physicians?
Well, I think it became economically driven to large extent, because, of course, one of the things that happened, the cost of medicine, health care, it increased so precipitously that everybody realized something had to be done, and there was an opportunity, I think, for people with a business inclination to come in and to the healthcare situation, and with thinking that maybe there's an opportunity for them to make money, I suppose.
Before managed care really got started, there was Medicare and Medicaid.
Mm-hmm.
When those began in the 60s, what did you think about them?
Well, I think Medicare came in around 1965, maybe, and I know most doctors at that time were opposed to it, because they just, there was a great opposition in general to having government enter into health care, but people's concerns were that when the government got in, that they would start calling the shots, and of course I think they're correct. When the government does come in, they start dictating as to what will take place. And so I know in '65, most doctors were not in favor of Medicare. I think that it turned out that they probably were benefited economically from Medicare more than they had ever anticipated, because there used to be a lot of free care given by doctors. And there were lots of clinics. Part of a prerequisite for being on a medical staff in that era was that you'd work in the clinic one afternoon or one morning a week or something, and there used to be lots of people who used these clinics, and the doctors weren't compensated. There were no fees usually charged to the patients, and these people were all taken care of gratis. And suddenly, with the onset of Medicare and Medicaid to some extent, everybody was now a full paying patient, even though the rates that the Medicaid allowed probably were less than what the private practice group were charging. So that the doctors actually were now paid for what they used to give away.
Do you think everybody who needed care was able to get it at that time?
Well, in Worcester they were, and I can only speak firsthand for Worcester, but I'm unaware of anybody in Worcester who was unable to get medical care that was needed. Now whether they were getting the kind of long-term personal managed care of all of their health requirements, I don't know, but I mean certainly nobody was dying of a perforated appendicitis because a surgeon wouldn't operate on them, and they weren't delivering at home because they weren't allowed into the hospital, things of that sort. Now whether people's health habits were being counseled individually in every instance, I don't know, but I don't think that happens today either. I mean, there's a large many people who don't have close personal contacts with doctors. They go in a crisis situation.
Have you had any involvement with the Central Mass Healthcare or Fallon Clinic, and how has that changed the Worcester area, access to care in Worcester?
The Central Mass Healthcare?
Yeah, or Central Mass Healthcare Plan, or basically the Fallon Clinic. How is that?
Well, of course, the Fallon Clinic was here before I was. I think it started around before the World War II, around 1939, 1940. And for a long time, they were not very popular amongst all the other physicians because they were a closed panel group. So that when they came into an institution, and they were up at St. Vincent's in their early years, they only referred to one another, whereas most other physicians referred across the board. So I was at Memorial, so we didn't have much contact with them, but I know there was a considerable hostility in the early '60s towards closed panel groups, and then of course this all changed, and the Fallons expanded enormously, became a very important player in Worcester healthcare, and they've done a fine job too.
How did the university coming here affect medicine in Worcester?
Well, how did it come in here, or how did it?
How did it affect the hospitals or the physicians in Worcester?
Well, I think in general it's had an uplifting effect on the quality of medicine in Worcester. It's happened rather slowly and gradually, but now it's accelerating tremendously. And the medical school started out very slowly. As you know, it started with 16 students maybe or so, and then it expanded. In the first few years they didn't have a hospital. The school started before the hospital, so that the students used to rotate to the community hospitals at that time, and the the professor of medicine became the chief of medicine at Memorial, and the professor of surgery was the chief at St. Vincent's, and then eventually they got their own hospital, and they were small in the beginning. They actually depended upon other hospitals for referrals, etc. And then, of course, they've grown tremendously, and now with this merger with Memorial, I would say they have become the dominant player, only left with 2 hospitals in Worcester. We used to have many, many more, and most of the positions of authority are now rest with the medical school, so that they're going to determine the direction of healthcare. And they obviously have a big base of specialized people, and I think they bring a lot to the city.
You mentioned the mergers with all of the hospitals now. Has that been a positive?
Positive for whom?
Well, I guess for the patients. Has it been a necessary step?
Well, I think it was inevitable. I mean, this has sort of been the direction of the world for the last 30 or 40 years, mergers and acquisitions and centralization and et cetera. So that it was inevitable, I think, that the smaller hospitals would disappear, or at least or assume a different role, because 35, 40 years ago, every hospital could do almost the same thing. The technology was not so great that the same thing couldn't be done almost in every institution, where they all had X-ray machines. They didn't, and there were no such thing as CAT scanners and NMRs, etc. And then as the new technology evolved, suddenly, if you couldn't take a CAT scan, you were not offering the patient the same level of care as a bigger institution that could afford a CAT scan. And this went across the board, you know, with dialysis, renal dialysis became more frequently used through the years, and then bypasses and open heart capabilities, and what the bottom line was, that small hospitals just couldn't afford this technology, so it's inevitable that they would disappear and consolidate. And then the economics, again, the economies of scale that large institutions could offer, I think put the small hospitals at a serious disadvantage.
You said you grew up here in Worcester.
Mm-hmm.
I want to talk a little bit about how Worcester has changed as a community.
Mm-hmm.
When you were growing up, what was Worcester like?
Well, it was like a big town in those days, and more people lived in Worcester in those days than lived in the suburbs. Of course, Holden was a very small place. Paxton was a village practically in the 1930s and 1940s, and the transportation systems weren't as good, etc. So Worcester at that time was over 200,000 people, and the downtown was a big, thriving area, and everybody used to converge on downtown at that time. It was a big trolley system. There were trolley tracks that ran all over Worcester, and we went down to up and down Belmont Street and Shrewsbury Street, down to the lake, and out to all parts of Worcester, and all the trolleys used to be. When you go downtown in front of City Hall, there might be 10 or 15 trolley cars going by in different directions. And this was so. The last trolley ran in. I was a senior in high school. It was about 1947. The last trolley car took its run. I remember we were coming back from a basketball game at South High, and it was the night of the last trolley car. So there used to be a lot of public transportation. A lot of people didn't own automobiles in that day. It was during World War II. There was first of all, gasoline was very difficult to come by. Tires were almost impossible to come by, so that even having access to an automobile during the 40s was somewhat of a luxury, and I don't think there was as much wealth around as there is today. And a lot more affluence. A lot of people just couldn't afford automobiles in that era.
And did you go away for college?
I did, yes. I went away in '47. I went to Harvard.
Okay. And after going to college and medical school and residency, when you came back here, had the city changed at that point?
It's changed tremendously. Of course, whenever you come back to your hometown where you were a boy, you come back as an adult, you know, you have a whole different perspective on it. You're interested in different things, and most of your friends from your school days have probably left the area, so you make a whole new circle of friends. Things do change with time, and your interests change. I went to North High School across the street from the art museum, and nobody ever told me to go inside. So we used to sit on the front steps, and it was one of the great deficiencies of my education in high school. I've been in since.
What are some changes you've seen in the demographics of Worcester?
Well, I was going to mention that. Yeah, the demographics have changed absolutely tremendously. Of course, when in the 40s, in the 30s and 40s, it was purely a white Caucasian city, and I mean now, if you go downtown, you can see the tremendous shift in demographics. There are all kinds of different ethnic groups. We always had lots of ethnic groups here, but I guess they were all European ethnic groups that we were seeing, and there were enclaves of different ethnic groups. And you know, Shrewsbury Street was always the Italian area, and Grafton Street had a lot of French, and there were Albanian areas and Lithuanian areas and Polish areas, and of course the people, a lot of those people were just one generation away from having immigrated, so that they often spoke their own languages, the parents, etc. And then now this has all changed. We're probably seeing the same thing now, only the people are just coming from different parts of the world. And I mean, now I don't think I'd ever seen an Indian from India until I suppose till the 50s, till after World War I. There just were no Indians around here. We had very few Chinese. Now it's not at all unusual, of course, to see some Asiatic people, and I think the black population has increased. I know it has. When I went to high school, I think there was one black woman in my class. Subsequently, she became a medical technologist, and we worked together at Memorial Hospital. But I don't know whether my children have all left high school now quite a while ago, but I suppose if you were to look at North High School today, you'd see many more blacks, and there's tremendous change in the demographics, bottom line.
The fact that there is such ethnic diversity in Worcester, how has that affected medicine, do you think? Well,
I don't know whether it's had a big impact on medicine itself. I mean, the patients still need care, and we've had some obviously, as these various ethnic groups come in, we have some physicians out of the different ethnic groups who join our medical staff, etc. I might add that in the old days, I know they used to have a difficult time getting on medical staff, so that that's changed. I mean, there's certainly no discrimination today based on any kind of ethnicity, but I think before I got here, I had nothing to, it wasn't because I was here that it changed, but I think that people did have difficulty getting on medical staff in the 30s and 40s, and depending upon their race and ethnicity, etc.
How has the role of women in medicine changed?
Well, it's gone from having a role as nurses to positions of serious major influence now, and of course the numbers of women physicians has increased tremendously.
Has that had an effect on women's health, do you think?
Well, I don't know that it hasn't. I mean, that implies that the male physicians who cared less about women's health than women might care about women's health. You have to remember the male physicians were sons of mothers and husbands of wives and fathers of daughters, so that they had very much of the best interest of women at heart. I don't think that just because there are women doctors that they can necessarily treat women better.
I think it's a very good point.
It depends on the physician, I think.
Yeah, I think it's a very good point.
Do you feel like the public perception of physicians has changed over the years?
Well, I think we're still held in very high regard, and I think that we have to continue to do the things that make us held in high regard. I suppose we were perhaps patients are more questioning of physicians, and they're less willing to accept authority. But I think in the final analysis, patients do like physicians who are strong and give them good advice and good serious recommendations. And I think patients don't want to have to make all the decisions themselves. They want somebody who's knowledgeable to tell them, this is what I think is the best thing for you to do.
Why did you choose medicine as a career?
Why did you
choose medicine as a career?
Well, I don't know. I always wanted to, ever since about the 8th grade, when I realized I wasn't going to play for the Red Sox, I thought I wanted to be a doctor, and I originally thought I wanted to be a family doctor or internist, and I didn't really have a particular role model in mind, but and then as I got into college and I became a pre-med, I was very much attracted to the scientific aspects of it, and I've been very happy with my career.
What can you say, if there's anything in particular you've most enjoyed about being a physician?
About being the most enjoyable thing about?
Yeah.
Well, I don't know, I think you get a great deal of satisfaction about participating in the care of people, even in pathology, where you're somewhat removed from the patients. I think if you think that each one of your decisions actually has a big impact on what's going to happen to somebody, that it gives you a great deal of satisfaction to know that you've been part of the team.
Do you think over the years doctors work more as a team, or has it become more individualistic?
Oh, I think we work more as a team now. I mean, we think we have to, because we're so specialized that I mean, the care of a patient now is really multidisciplinary.
For young physicians going into pathology now, what advice would you have for them?
Well, I would say, if you're going to select any career, select a career for something you think you'd enjoy doing, and don't select it for the material aspects of the career, because they'll take care of themselves. I think this applies to medicine in general. I mean, I hear some people saying, well, I'm leaving medicine because I'm going to start this company or that company and I can make more money. I think that's probably the wrong motivation to get into medicine with in the first place. And so you ought to go into something that you think you're going to enjoy doing. There'll be a great deal of satisfaction in helping other people, and if you come into medicine or a specialty with other motivations, you're probably going to be disappointed because it's probably not going to play out the way you expected it. And of course, you have to. Nothing you get into is going to be perfect. I've never had a job of any kind where everything was perfect. There's always a downside. When you think back to your days in college, you'd say, gee, I have 3 great courses this year, but I have to take physical chemistry. Wow. Isn't that bad? That's going to ruin the whole year. And it's been that way ever since. And you'll have the same thing in medicine. You'll say, oh, I love doing surgical pathology, but I have to look at pap smears. Isn't that lousy today?
Is there anything else that you want us to know about your career or your thoughts on medicine?
Oh, I think we've covered a lot of ground.
Okay. Great. Well, thank you very much.
Okay, you're welcome.
Really appreciate you.